Okay, so apologies if anyone in attendance today attended the HSST celebration event, because it's the same talk I gave at that event, but otherwise, hopefully this is all new to everyone. And I'm going to talk about how I got onto HSST, or what the decision making was in HSST, and then moving forward and where I have got to, really, with a few lessons and tips and tricks on the way. So in terms of my career, so did my undergraduate degree in Nottingham, did my MSc under what was the IPEM training scheme before the STP came around, and at the same time was finishing off my PhD at Nottingham before taking on a MR Physics post at Leeds as part of the National Institute for Health Research centre that had been set up. And during that time, I actually dropped out of the IPEM training scheme at University Hospital North Midlands because they hadn't got an MR training post available. So I dropped out, went to Leeds, where I was able to continue my MR work and did a route to HCPC registration. I then actually ended up going back to North Midlands and setting up a physics MR and non-ionising service, where I was there for 18 months before a role came up at Sheffield. And it was at Sheffield that the initial expressions of interest were put out for HSST. And there'd been a lot of talk on my channels nationally about equivalence and where equivalence was going. And this was the first opportunity for expressions of interest, which would have been into cohort 2. I weighed up the options and I thought, well, actually, HSST does look like it could be for me. So it was at Sheffield that I started HSST, but partway through Sheffield, partway through HSST, I should say, there was a role that had been advertised. I thought, well, you know what, I'll apply for that, and if I get an interview, it'd be a great interview experience for when I finish HSST and feel more confident about being able to go for these, head of medical physics type roles. But in fact, I went for the interview and ended up getting the role. So moved during my time doing HSST into the lofty title of Director of Healthcare Science and Technology here down in Plymouth, which is effectively Head of Medical Physics and Clinical Engineering, with a few other bits added on. So as I alluded to, I did have a decision to make about HSST because equivalence had been talked about, and looking at what was required for equivalence, I felt that I could have done that. But for me, I felt that the importance of the leadership part for HSST was really why I wanted to do it. And those of you that have done or completed the Manchester University modules will know of the great resource that they have been, and the information and education that you get from that. And that helped reinforce and vindicate my collaborative leadership style, because I'm sure some of you or all of you will have met one or two individuals that had, or if they're still working, haven't retired, the God complex, and that sort of leadership style. When you're exposed to it day in, day out, can start to inadvertently influence your potential leadership style. So doing the HSST leadership did help reinforce and vindicate my collaborative leadership style. And those of you that are in leadership roles will know, however, that you do need to be directive at times. So we're all aware of the adaptive leadership. Now, when I did move to University Hospitals Plymouth, because of the seniority of the role and the work needed to get myself up to speed, really, I took the decision not to undertake the research project, and I cashed in my PhD. Looking back on that, in hindsight and with rose-tinted glasses, it would have been nice to have done it, but I still think it was probably the right decision with the amount of workload I had at the time. But then when I was at Plymouth, I also took on other roles. So in April 2019, the role of the Trust Lead Healthcare Scientist came up. And the work that I was doing within my medical physics teams directly correlated and overlapped with work I could have done with other healthcare science professions. So I felt that role could really help. And then in June 2020, I took on another role as Associate Director of Clinical Professions, which led to professional accountability for the allied healthcare professionals within CSS. So that was the radiographers and the therapists. Now, my first advice would be is at the earliest opportunity, roadmap your career. And where do you want to be, or what do you want to do in 5 to 10 years' time? And I think, again, in hindsight, the reason I say that is because you can look at what I've described as my career to date and say, well, actually, I have climbed the slippery promotional pole quite quickly and quite well. But the reality is that's all within an NHS organisation. And if you were wanting to explore the more regional or national working, make sure that's in your roadmap and make sure that you do it at the right time. So if I now looked at those opportunities for the secondments and things like that, I am in, and I will admit in this forum, you end up in that pay trap, where those secondments are offered at a lower band, and therefore you can't afford, because you live within your means, you can't afford to take those secondments unless you take a pay cut. So do make sure you know where you want to be in 5-10 years time, and you do jump at those secondments before you get to the point where you necessarily couldn't undertake them. So moving on from HSST, what have I done to date and how has HSST helped me? So I have developed a service within MR, so within my own specialty as a non-ionizing physicist. We scan patients here at Plymouth with cochlear implants and cover the whole of the southwest. So that has been a great service development for patients within the region, although accepting that they are now having to travel as far as the likes of Bristol to come to Plymouth for their scans, but at least they can get them. Both during HSST and continuing afterwards, we've done service developments with functional MR, diffusion tractography, spectroscopy, which is helping with patients with central nervous system tumours and epilepsy. And in fact, here at Plymouth, we've actually got functional MR and specialist neuro scanning actually commissioned, so we're able to fund the physics time to support that, which is quite a good leap forward. We all want to be doing research, but what you find is when you move into the more leadership level roles, I found that I am supporting healthcare scientists and AHP colleagues with the clinical professions role more in supporting them in doing research rather than doing my own research. And I still do get to do a bit of my own research, but I think my focus is on enabling others to do it. And that has led to development of clinical academic posts, as well as supporting colleagues with NIHR, predoctoral and doctoral fellowships, with more in the pipeline, as I said. But even with that, in recognition, I was very lucky to be offered a chair in October 23 with the University of Plymouth through my research with the Brain Research Imaging Centre. So squeezing all that in has helped with that recognition. And as part of HSST and moving on from HSST, I've still been involved in regional and national input. So we did a regional work with my MR physics team and with other teams in other bigger trusts within the region to standardise protocols. So, for example, in the southwest now, if you were to undergo a prostate MR scan, the prostate MR scan you received in Bristol would be the same as the scan you'd receive in Exeter and would be the same as the scan you'd receive in Plymouth. And that has meant that patients aren't needing to get one scan one place, and then if they're referred to a specialist centre, get another scan, they have all received the same scan that all the radiologists accept and interpret. So the patient only needs to be scanned once. And the gold standard or the holy grail with MR would be being able to do that across the board, because you have lots of different protocols across lots of different trusts and sites, which means that you still do get that in other areas. And within the role, but also with the leadership recognition on the HSST, I have been the senior responsible officer for a number of large implementation projects for capital procurement, and most notably implementation of radio frequency identification across the trust, which has enabled medical device tracking and theatre tray tracking, so theatre equipment that comes from the sterilisation unit into theatres and back again, so that there's that full traceability. And with my work on MR safety and those other areas, I've also been asked to consult for a couple of companies, which has really helped not just enable individual patients to get their scan, but it's also enabled the companies to refine and develop their own processes and paperwork and things to the benefit of my own specialist community. And then there's more general leadership. So as I've said, not only do I support the wider healthcare science community here at UHP through the healthcare science trust leadership role, but I also support 70% of the AHPs within the trust, and that's been with everything from general workforce things to research, predoctoral fellowships, and research orientated roles. I've supported the development of consultant and advanced clinical practitioner level roles, mainly within healthcare science. So, for example, within histopathology, we trained and recruited the first dermatopathology reporting consultant clinical scientist in the country, which was a real coup, because any of you working within pathology will know that skin histo is usually your biggest demand within the team. But I've also looked at harmonising healthcare science and AHP roles. So those of you may or may not know that AHPs come into the profession with an undergraduate degree for HCPC registration, and us as scientists undertake the postgraduate qualification to become HCPC registered. But by the time you get to the advanced clinical practice and the consultant level roles, the qualification and the standards start to equalise out. Yet there is a huge discrepancy in what the national bodies say for pay. So we know that through the NHS providers job profiles, the consultant job description for a healthcare scientist starts at 8D, but for an AHP it can range from a band 8A to an 8C. So within my own organisation, I have been promoting reducing that gap between consultant healthcare scientists and consultant AHPs, such that the advanced clinical practitioner starts at the 8A, and the 8B is the training for a consultant AHP into an 8C role. So it's not quite there fully, but I'm still trying to reduce that with the support of both the chief nurse and the chief and the medical director at exec level. And I've worked with other healthcare science professions, so histopathology, for example, and their workforce development, which is still ongoing. But again, as I said, with the consultant role, and neurophysiology is a great example where we are short of medical consultants, and healthcare scientists are stepping into the breach, not only with reporting, but I also supported our lead neurophysiologist in now undertaking registrar equivalent training in needle EMG, so that she can take on that work that would have been done by a consultant where our consultants have retired. And something else I do to support those leaders within their specialties is appraisals of service leads, and that I do in conjunction with their service line manager, so they have the professional aspect and that managerial aspect. But also then we'll move on to things like trust-wide research strategies, working in progress with the medical director. But with all this, my advice, point 2, would be learn to say no, especially when you do move into new roles, because people will want you to take on some of their stuff. People will want you to try and do things, but you can't do it all. But people will let you try. So do learn to say no. And I probably would argue I learned to say no, not routinely, but with confidence, a little too late. I was keen to try everything, keen to attempt everything, which meant that my portfolio did grow potentially beyond what was capable. And where do we go from here? So with HSST under my belt, supporting our regional scientist with attempting to get funding for the Trust Lead Healthcare Scientist. And again, looking at the audience, how many of you, 1, know who your lead healthcare scientist is, and 2, do you know if they're funded or not? I'm not funded, hence attempting to get funding, yet I am the only Trust Lead Healthcare Scientist in Devon, which does cause some challenges in where there might be potential benefit in looking at regional services, for example, or at least collaboration with individual services across trusts. And we know from government that there is a move to acute community, and it's how do we support our CDCs. We've got that move from analog to digital, for example, supporting virtual wards and how we can support moving patients from the acute setting into virtual wards before so that they can actually go home earlier. And it's important that we don't just silo ourselves within the healthcare science profession. We need to collaborate with other professions. So that's the medical profession, the AHPs and the nurses, to achieve the same goals. Because we do want to progress our own careers and the careers within our teams, but we want to do it to the benefit of the service that we're providing. And if we can do that in collaboration with those other professions, then we absolutely should. And the point that I do hammer home to my own managers is that research is often deemed a nice to do. It's all about the operational, it's all about the targets and the KPIs and DMO1 numbers and things like that. But as scientists, we absolutely are the ones that can introduce that change and that influence into improving technology, improving patient pathways to improve those KPIs and those targets. But we can only do that if we're given the headspace to do it. So we need to change the culture across organisations, across the NHS, so that we are enabled to carry out that 5th pillar of research. And evidence is out there that those research-led organisations achieve better patient outcomes overall and achieve better CQC ratings. So we absolutely should be selling the benefit and the need to do research and innovation. And I'm coming to the end of my talk now, but my final advice would be remain compassionate. As leaders, we need to remain compassionate now more than ever. Many of you will be acutely aware government has prioritised defence now, which means funding will be moved into defence, likely away, well, we know, away from other areas like healthcare. As a result, trusts and ICBs and regions are tightening belts. May or may not lead to redundancies or the potential for redundancies within your own trusts. And so we need to remain compassionate to that while still trying to maintain our services and improving our services so that we can still deliver more with either what we've got or potentially less. Okay. On that note, I'm going to leave it there and say thank you very much for listening.